In 2007, I had my first cesarean. I was 41 weeks pregnant, a week past my due date. I had no medical indications for needing to be induced, but my doctor insisted that I needed to be induced to protect my baby. That induction took place in August of 2007 and ultimately ended up in a cesarean due to fetal distress caused by the inducing agents. In 2009, I had my second cesarean. This cesarean, I had attempted to have a vaginal birth. However, I was given inaccurate information about the safety of using induction agents during my labor and ended up in another cesarean. According to Grady, the cesarean rate in the United States has rose to 32.3%. This is more than twice as much as what the World Health Organization recommends the cesarean rate be, which is only 15%. According to Norton, 44% of women have induced labors, meaning that their labor is started artificially using drugs such as Pitocin, Cervidil, or Cytotec. These drugs are known to increase the incidence of cesareans. Of these 44% of women, 40% had their inductions done for elective reasons, meaning they were not medically necessary. Of all the cesareans performed during this study, 20% were the result of a failed induction. Most women are unaware of the risk of having a cesarean. They go into the induction thinking that they'll get drugs, they'll have a baby, it'll all be fine. However, if an induction is performed before the woman's body is considered favorable, she's practically guaranteed a cesarean. There are many reasons women may want an induction. Some may be medical, but when an elective induction is done, it's usually due to comfort, convenience, or just being anxious to meet their baby. Another reason inductions are done for non-medically necessitated reasons is for macrocemia, otherwise known as a big baby. The problem with diagnosing macrocemia is that ultrasound technology, although it's capable of estimating the weight of an unborn baby, is inaccurate and can be off by up to 2 pounds in either direction. This means that if your doctor tells you that your baby is about 7 pounds, your baby could be as light as 5 pounds and as heavy as 9 pounds. It is not a good idea to base the decision to induce labor on macrocemia alone. Lastly, there's the question of greed. Although we can't prove it, the cesarean rate in America could be due to greed in terms of time and money. For example, my first cesarean cost my insurance $32,000. My second cesarean was $36,000. My third delivery was a vaginal birth after a cesarean, and it was only $8,000. If you were asked if you would like to work less and make more money, what would your response be? Most people would say yes. In addition, there's also the time factor. A vaginal birth can take hours, sometimes even days, while a cesarean can be done in less than an hour, barring any complications. Vaginal birth after cesarean hasn't always been considered safe. Several decades ago, cesareans were done in what's known as the classical way, where the incision is made beginning in the mother's navel and ending at the pubic bone. Now, in the last few decades, they've been done in what's known as a bikini cut, or the low transverse cut. An incision is cut horizontally along the mother's pubic bone. This incision is much less likely to rupture during a vaginal birth after a cesarean. According to the American College of Obstetrics and Gynecology, the cesarean rate in 1970 was only 5%. Most of the women who had cesareans then would have their subsequent children by a cesarean due to the belief that doctors had of once a cesarean, always a cesarean. Although the vaginal birth after cesarean rate continued to climb until 1985 when it peaked at 28%. After this peak, it dropped down to 8% in 1996. There is no definite cause for this drop in vaginal birth after cesarean rates. However, a lot of restrictive hospital and caregiver policies went into effect that made vaginal birth after cesarean more difficult to achieve. This could be the reason why the rate dropped so drastically. These policies were put into effect due to a fear of uterine rupture. Because of this fear, many caregivers refused to take on patients who were attempting a vaginal birth after cesarean out of fear of their uterus rupturing during labor. According to Ina Mace Gaskin, a world-renowned midwife, A woman who undergoes a repeat cesarean is 3 times more likely to die and has 5 to 10 times the chance of suffering complications from her cesarean than she would from a vaginal birth after her cesarean. I'm a birth doula, and many of my clients believe it's safer to have a baby via repeat cesarean than a vaginal birth. This is inaccurate. According to a study conducted by Menaker, he concluded that the neonatal mortality rates were not any better for cesarean-born babies than vaginal birth after cesarean-born babies. In July of 2010, the American College of Obstetrics and Gynecology released new, less restrictive guidelines on who made a good candidate for a vaginal birth after a cesarean. These new guidelines included women who had 2 previous cesareans, were carrying twins, or had an unknown scar shape on their uterus. According to Cohen, a vaginal birth after cesarean benefits the mother in many ways. She's less likely to die. She's less likely to suffer from hemorrhage or from infection. She's also less likely to suffer from psychological problems after the birth. It's also easier to breastfeed, and the financial burden of a vaginal birth after cesarean, as you can see from my previous example, is much less than a cesarean. A vaginal birth after cesarean also benefits the baby, as they're less likely to suffer from iatrogenic prematurity, which basically put is doctor-caused prematurity. The baby is taken from the mother's body before it's ready. This can happen for a variety of reasons. Some babies just need longer time to gestate, and sometimes the dates are inaccurate or have been calculated wrong. In addition, the baby is less likely to suffer from surgical complications, such as lacerations, broken bones, and other things related to the cesarean. They're also less likely to die. Although the safety of vaginal birth after cesarean has been established for quite some time, women continue to opt for and end up with repeat cesareans for many reasons. For one, these women are inaccurately informed. They have mothers and grandmothers who are telling them all the things they were told back when their generation was young, that once a cesarean, always a cesarean. Mothers and grandmothers are telling their daughters and granddaughters that they have to have a cesarean. It's not safe if they don't. But this isn't true. These women are uninformed of what the new studies have shown and what the statistics truly are. And so women are opting for unnecessary surgery out of fear based on outdated information. Additionally, there are lots of caregiver policies and hospital policies that make a vaginal birth after cesarean a difficult feat to achieve. I myself faced this when I was planning for my own vaginal birth after my 2 cesareans. The hospital in my community had a ban on vaginal birth after more than 1 cesarean, which made it nearly impossible for me to deliver locally. I ended up traveling 5 hours to have my own vaginal birth after a cesarean with a doctor who was supportive of my choices. And lastly, inductions play a large role in the rate of cesareans. Inductions, because they don't allow the body to progress naturally, are more likely to cause a cesarean and fetal distress. Women can increase their chances of having a successful vaginal birth by preparing ahead of time. Women should interview their caregivers thoroughly. According to Ina May Gaskin, women should choose a caregiver who has no less than a 70% success rate of vaginal births after cesarean. Additionally, they should interview their caregivers very thoroughly and ask questions such as, what is your personal view on VBACs, vaginal birth after cesarean? If a doctor doesn't seem very enthused about them, this is most likely going to reflect in his care of his patients, and she may be less likely to have her vaginal birth after a cesarean. How do you manage post-date pregnancies? This is especially important if you tend to gestate longer than the usual 40 weeks, because many physicians will try to rush to a cesarean or induction as soon as the due date is hit, when in fact it's normal for women to continue their pregnancy up to 42 and even 43 weeks in some cases. It's also a good idea to ask your prospective caregiver what their view is on inductions in women who have had a vaginal birth after cesarean. Inductions are contraindicated in women who have had cesareans before and want a vaginal birth. So a doctor who seems ready and easy to give an induction to a woman intending for a vaginal birth might not be a good choice, as they might begin to pressure the woman should she go past her due date. Lastly, you should ask the caregiver if they've ever been involved in the care of a patient who's had their uterus rupture and what the outcome of that care was. This can give you an idea of what might happen if the rare event of a uterine rupture occurs. According to Juklovics, women can maximize their chance of having a successful vaginal birth during pregnancy by avoiding a late ultrasound screen for macrosomia. As we discussed previously, macrosomia is simply a big baby. Getting induced for the reason of a big baby alone is not a good idea because of how inaccurate the ultrasounds can be in estimating weight. Second, she recommends to avoid the use of any inducing agents such as Pitocin, Cervidil, and Cytotec. And lastly, she recommends that patients should have an early ultrasound, ideally between 5 and 10 weeks, to determine the dates of the pregnancy and when an accurate due date would be. Ultrasounds done between 5 and 10 weeks are much more accurate in predicting dates than ones that are done later in pregnancy. According to Ina Mace-Gaskin, women can also increase their chances of having a successful vaginal birth by refusing IV fluids in labor unless they are medically indicated, as well as eating well before going to the hospital. This is especially important in hospitals where women are not allowed to eat and drink during labor. It is important that when choosing a place to give birth, you ask their policies on eating and drinking during labor, as this can affect your labor. Next, she recommends to keep vaginal exams to a minimum, especially once the water is broken. Vaginal exams can introduce bacteria to the vagina, which could lead to an infection, which would necessitate a cesarean. Lastly, you should refuse an epidural and other pain medications, as epidurals and pain medications have been linked to stalling, slowing, and even stopping labor in some cases, something that with a cesarean would lead, something with a vaginal birth after cesarean would lead to a cesarean. Additionally, there are other complications that these drugs can cause. Many women are being misled about the safety of vaginal birth after cesarean due to this outdated information and inaccurate beliefs about the safety. Women are being rushed into surgeries that aren't necessary and are actually life-threatening due to outdated information. Women are also being cared for in a manner that increases the likelihood of needing a cesarean, such as the use of inductions and the sternness there is with due dates. It's a due date, not an expiration date, and it's normal to go past your due date by up to 2 and even 3 weeks in some cases. Cesareans have their time and place when they are necessary and needed and life-saving. However, we shouldn't be pushing our women into these routine surgeries for no reason. These surgeries carry risk, and this trend of having a repeat cesarean simply because you've had a cesarean before is dangerous and life-threatening to our women and their babies. The key to reducing the cesarean rate in the United States and increasing the vaginal birth after cesarean rate is education and information. Our women need to be educated, as well as their families and their caregivers. That way we can better protect the health of our women and their babies.